coming through, collecting the vote.
Hello, everyone, and welcome to the Mindgardens TRSP Webinar Series. My name's Julia Lappin. I'm the Clinical Director for the New South Wales Tertiary Referral Service for Psychosis. I'm a clinician and researcher working as an Associate Professor at UNSW Discipline of Psychiatry. And over the past 20 years, I've been working clinically and in research aimed at improving outcomes for people living with psychosis. So I'm very excited to be welcoming Prof. Dan Siskind back to give us a talk on clozapine today. But before I do so, I'll begin with an acknowledgement of country and of lived experience. I acknowledge the strength and resilience of Aboriginal and Torres Strait Islander people, who are the traditional custodians of the diverse countries from which we're joining this meeting. I'm privileged to be calling from the land of the Gadigal people of the Eora Nation. I pay my respects to elders past, present and emerging, and extend that respect to all Aboriginal and Torres Strait Islander people present today. I also acknowledge people with lived experience of mental ill health and recovery, and the experience of people who have been carers, families or supporters. So the TRSP Webinar Series is supported by the Mindgardens Neuroscience Network, and TRSP is a New South Wales Health funded statewide service hosted by South East Sydney LHD. We're very grateful to South East Sydney LHD, New South Wales Health and to Mindgardens for their ongoing support of TRSP. The Mindgardens TRSP Webinar Series ran throughout 2023 and we hope to keep it running through 2024. It occurs on a monthly basis and we'll have information about our next webinar at the end of Dan's talk. Also, please look out for emails from TRSP events which will detail future webinars, all tailored for clinicians. A little bit of housekeeping. Participants, you can write your questions in the Q&A, but you can't speak or be seen. And there will be a simple anonymous poll towards the end of the webinar. Please complete it so that we know how to keep these webinars of interest to you. We also appreciate your feedback by email, including topics you'd welcome for future webinars. The event is recorded and we'll distribute a link to the video within 2 weeks to those who provide us with an email address. Finally, it is my great pleasure to welcome Dan Siskind, who's a friend and colleague at University of Queensland. Dan trained as a psychiatrist in Australia and the United States. He works clinically as a psychiatrist in Brisbane with people with treatment refractory schizophrenia. His research interests include treatment refractory schizophrenia, clozapine, and the physical health comorbidities associated with schizophrenia. He has over 230 publications and over 50 million Aussie dollars in competitive research grants, with over 6.5 million as lead investigator. I'll hand over to you now, Dan, and I'll join again at the end for Q&A. Thanks.
Thanks so much, Julia. I'm absolutely honoured. Just a quick housekeeping. If I wanted to interact with the audience, would that be in the chat or the Q&A or which section?
That will be in the Q&A.
Wonderful. Okay, tremendous. Does one of you guys in the audience want to type something into the Q&A just to see that I can hear from you? I'm mute. Okay. Hello, Tara. Great. Thank you. Oh, g'day, Mel. Thanks. Oh, hello, Tiara. Cynthia, this is wonderful. Oh, look, I am touched that everyone's here. And I can see that someone's raised their hand. Does that, do I take some action with that, Julia, or I just say hello to everyone? Okay, Franco. All right, Rahul. This is great. So I see we've got 95 participants, and I'm absolutely honoured that you guys are here to see Julia today. To disappoint you, I am supplanting Julia for the purposes of this talk. And it was an honour to be invited to speak to Mindgardens last year, where we talked a bit about clozapine and augmentation strategies, but didn't have time to talk about how to manage some of the clozapine-related adverse drug reactions. So we're going to focus on that. My assumption is that no one can remember anything I said last year because I was soporific. So I'll do a quick little touch over the history of clozapine and why it's beneficial, and then we'll dig right into some of the adverse drug reactions associated with it. I will seek for you guys to create some clozapine coordinators. Wonderful. Seek for you guys to answer some questions in the Q&A. Can only I see the Q&A, or can everyone else see the responses, Julia?
We can all see Q&A, Dan.
Okay, let's get among it then. So what I'm presenting to you guys today is a wonderful colleagues of mine from the pharmacy department, from the Griffith, from the UQ School of Medicine, from some of the psychiatry registrar projects, and in fact, actually far too many people here than I can name right now have contributed to what I'm presenting to you today. Okay, so anyone here done a clozapine clinic? I'm assuming you have. Okay, some people have raised, yes, people have raised their hands. That's wonderful. All right. And then who thinks clozapine is benign? All right. No one's putting their hand up for that one. And then who feels completely comfortable with their skills as a clozapine prescriber? And I can't put my hand up for that. So I will, within seconds after leaving this talk with you guys today, I will go to run my clozapine clinic. And I guarantee you that someone will raise a question for me in this clinic where I have no idea how to answer it. And I will have to go off and do some research into how I should be approaching the problems. And that's what I love about working with people with treatment-resistant schizophrenia, is that they're inquisitive and complex, and there's always more work that we can do collaboratively to help improve the quality of their lives. So it's a privilege for me to be serving this community. So I'm going to talk about the history of clozapine, evidence of efficacy. We're going to move over that fairly quickly, and then we're going to head to adverse effects. So for treatment-resistant schizophrenia, to remind you, we define that as 2 adherent trials of first-line antipsychotics, and people have taken them for at least 6 weeks, had an adequate dose, and they've been adherent. And we've had ongoing symptoms and functional deficits. And about a quarter of people with first episode psychosis, including some work that Julia has done, found that these people transitioned on to having treatment-resistant illness. And in fact, another 8% of people will have adequate treatment response early on, but then later develop treatment-resistant illnesses. So about a third of the patients we serve with schizophrenia have treatment-resistant schizophrenia. And for those of us who work in the public sector, this is kind of our bread and butter, is working with these consumers and helping them with quality of life. And so the most effective medication is clozapine. Can anyone tell me what the first antipsychotic was? I'm looking in the Q&A here. Chlorpromazine, thank you so much. And can anyone tell me what year that came, it was developed? Ballpark figure, you know, what year we had chlorpromazine? Wonderful. So someone said 1948, actually a little bit, yeah, 1948, I think it was developed, sort of started being marketed around 1952, so the early 50s. And clozapine was developed in 1958, so very, very soon after clozapine came on the market. It's been around for 64 years. And much like this gentleman here, Wolverine, it sort of remains fresh, always young, always helpful. But much like Wolverine, they had some problems in the 70s. Can anyone tell me what issues arose in the 1970s? I'm confident someone was about to, deaths, exactly, Franco, thank you, yes. Some people developed neutropenia. Some of those went on to develop agranulocytosis, and some of those consumers went on to die. And it was in Finland. 6004035 beat me to the next question. It was in Finland. And we detected in Finland because they've got great national data sets. So they were able to do data linkage and detect this. But usage recommenced in the 90s in most jurisdictions around the world, and in Australia in 1993. And so this is a kind of a plot of usage. And again, it's a little bit old, this data, it's 10 years old, but you can see there's this ongoing trend upwards for Australia. There's Australia there, some dots in the middle, ongoing upward trend. And we've since done another paper looking at the trends of usage of clozapine since 2014, and you can see the trend goes up. But remember we said about a third to a quarter had treatment-resistant schizophrenia. If we put that shading onto this plot of rates of usage, we can see that we're only giving people in Australia, maybe 1 in 4 people with treatment-resistant schizophrenia ever get 1 dose of clozapine. So this isn't prevalent clozapine. This is incident. This is anyone who ever got a dose of clozapine. And so we're wildly under-treating people with schizophrenia, treatment-resistant schizophrenia. In fact, only the Finns are more assertive in their approach. So why would I say we should use it? So John Kane, who's kind of the clozapine daddy, he's still actually an active researcher in New York, and an absolutely delightful and generous mentor. So looked at clozapine for treatment-resistant schizophrenia and found it was really effective in this trial versus chlorpromazine. We then did a meta-analysis, which was a scholarly project with some of the registrars in my service almost a decade ago, where we compared clozapine to all other antipsychotics. And what we found is for total symptoms, for short-term trials, clozapine was superior to other antipsychotics. For longer-term trials, more than 3 months, it wasn't statistically significantly superior. But when we disaggregated the results into positive symptoms, we found that clozapine was superior to other antipsychotics for positive symptoms, but not necessarily for negative symptoms, which fits with what I find in the clinics that I work in, where the consumers are not so bothered by the aliens or the bikies or the voices, but they're not that motivated to have a shower or leave the apartment, or kind of, work, find a job or train. So, and that kind of just goes to show what we already knew, which is negative symptoms are notoriously challenging to treat. But interestingly, a lot of the studies were done by pharmaceutical companies, and I was a medical student in the 90s and, loved going into the psychiatric ward because there'd always be a drug rep giving away free candy or cake or food or pens or something like that, because it was the era that olanzapine, risperidone, or quetiapine were hitting the market. And so all of the drug reps were saying, our drug is just as good as clozapine. We did this study where we compared it to clozapine for treatment-resistant schizophrenia, and we didn't find any difference. When we exclude the pharmaceutical-funded studies, clozapine is far superior to other antipsychotics. And then we drilled down closer to the pharmaceutical industry studies. What we found is that they were underdosing the clozapine arms. So if we convert dosage into what we call olanzapine equivalents, which is kind of a way of saying that, 10 milligrams of olanzapine is about the same as 200 milligrams of quetiapine or 2 milligrams of risperidone. We convert everything to olanzapine equivalents. People in the clozapine arm were getting 10 milligrams of olanzapine less. So that's kind of like saying if we give one group 5 milligrams of olanzapine, another group 15 milligrams of olanzapine, unsurprisingly, the group on a higher dose is probably going to have a lower psychosis score at the end of the trial. So when we exclude the studies that had the greatest difference, clozapine was again statistically significantly superior. What we also found was that baseline psychosis score predicted greater clozapine response. Now, for those of you who are hospital directors or managing budgets, this is the study I normally mention. Clozapine is very effective in keeping people out of hospital. When we looked at the number of bed days in the year before studying clozapine in a meta-analysis versus the year after, people on clozapine had around 34 days fewer in hospital after studying clozapine. And again, it reduced hospitalizations in most comparators. This is a study by Gentine Vermeulen, a Dutch psychiatrist, a very talented psychiatrist, who did her PhD on clozapine, looked at all-cause mortality rates for people who were on clozapine versus other antipsychotics. And you are half as likely to die if you're on clozapine. And this is the study I usually cite when I'm talking to, this is the study I normally cite when I'm talking to families who are trying to decide whether or not their loved one should start clozapine. You're half as likely to die. Simon, you've asked me about slow titration. We will get onto that a little bit later, a prescient question. So when we look at rates of clozapine usage, this is sort of a 10-year usage of clozapine in Queensland from the first dose to the last dose. I don't think, so people keep on raising their hands. I don't think I can answer a raised hand at the moment, so I'm going to apologize. And I think we'll have some Q&A towards the end, Julia, where people can talk. Okay, so
yes, we will, Dan. We'll have Q&A at the end, and if people could hold their questions until then, that would be fantastic. We'll have a good 10 minutes. Yeah.
Awesome. We'll make sure we make time for that. So when we look at usage of clozapine, after 18 weeks, about a quarter of people have stopped clozapine. But after 5 years, half of people are still on clozapine. And so that is unusual for an antipsychotic, that people like it so much that they want to remain on it. In the CATIE study, which is where there's a trial of lots of different antipsychotics where the primary endpoint was time to discontinuation, after 18 months, only a third of people were still on olanzapine. And that's with an attractive, pharmaceutical trials staff person, where they're getting some financial incentives for being involved. If you're on clozapine, you're getting me, some sort of ugly middle-aged psychiatrist. And so even with that, you're still having people choosing to remain on clozapine. Now, when I look at when I talk to my junior colleagues who are saying, look, this patient will never take clozapine, what I say is in the first 18 weeks, of the people who are going to stop it, 25% stop in the first 18 weeks, half stop in the first 3 weeks is often due to adverse drug reactions or just the fact that they're refusing to take it. So you're going to know really early on whether or not clozapine is going to be tolerable for consumers. Because if they get through those first 18 weeks, they're very likely to remain on. Now, the other biggest sign that something's popular is that someone's drawn an artwork for it. And so this is some fan art by an artist named Painted Bees. Optimists, if anyone's an optimist out there, put your hand up. I can see whether or not you put your hand up. I can't answer your question, but I can see anyone. Okay, we've got a bunch of optimists here. Wonderful. So optimists here might be looking at this and saying, this person started taking clozapine. There's an angel. There's a very bright future. The stairs are heading up to a positive, optimistic future for this consumer who's recently started clozapine. All right. Anyone here a pessimist? Pessimists tend to call themselves realists. They don't like calling themselves pessimists. They say they're realists. Okay. Vast number of hands going up amongst the realists. Thank you guys for your honesty. I mean, this is the honest group of the people here. And so the realists here are going to be seeing this person as a bit skinny. The pill bottle's dropped over. They're probably non-adherent. This angel is in fact not real. It's a psychotic episode, and they've realized. Okay, so a little bit of clozapine Rorschach humor there for you. So let's move on to managing adverse events, which is what I've been asked to do here. So Homer here is demonstrating some common adverse events associated with clozapine. Can anyone tell me some of the adverse events that Homer is demonstrating? You type into the Q&A any adverse events that you think Homer here is demonstrating. Hypersalivation, excellent, 600400353. Weight gain, wonderful. 600400353 has got some great answers here. Thank you for stepping up here. Cynthia noted that he is hypersedated. Cynthia's got some central obesity, wonderful. Sedation, hypersalivation, weight gain, wonderful. Wonderful, wonderful. Increased appetite, particularly carbohydrate craving. Good, increased BMI. Constipation, yes, perhaps he's got a little bit of a bulge there from some constipation. Lack of motivation and fatigue, wonderful, wonderful, wonderful. Okay, great answers, people. So when we look at these sort of adverse drug reactions, for clozapine, the most challenging adverse drug reactions, so we've got early onset myocarditis, later onset potential for cardiomyopathy, though I have my doubts, constipation due to slow gut contractile activity, neutropenia, agranulocytosis, obesity, often mediated by GLP-1, leptin and ghrelin, histaminic 1 antagonism, diabetes, which can be an ongoing issue from glucose dysregulation, hypotension, postural hypertension, and dyslipidemia. So I want to give credit to my colleague Daryl Isles and his team for making this particular slide. I really like it. Okay, so I kind of divide these adverse effects into the lethal ones, serious, disabling, and distressing. And I put constipation among the lethal effects because that's actually the #1 killer of people on clozapine. And in fact, the Cialarrhea can often be lethal when it leads to pneumonia through aspiration. Okay, so first of all, neutropenia. So neutropenia is a relatively rare event. Severe neutropenia of an absolute neutrophil count of 0.5 is pretty rare. 0.9% of people in this large meta-analysis by Nick Miles, who's doing a PhD with me. He's a hematologist. So fairly rare event. And so one of the challenges we have is that we've got this sort of threshold of 2 for an ANC count or 1.5 to kind of have amber or red range. But if you talk to the hematologist, they are not bothered by dipping of neutropenia. They get worried when the neutrophil count goes below 0.5. So we're probably excessively claiming that people have neutropenia, and we need to be revisiting these neutrophil thresholds. Mortality is rare. The case fatality rate of 2.1% among people who develop neutropenia, most of those case fatalities occurred over a decade ago before we had filgrastim and the other granulocyte colony stimulating factors. Because we monitor so well, it's rare for us to have neutropenia causing mortality now. It's greatest in the first 4 weeks. After 18 weeks, and it goes very low and it's negligible after 1 or 2 years. And these lab tests are a significant barrier. So my amazing colleague, Corrine Northwood, who I think is trying to plan to do a little sabbatical with you down in Southeast Sydney, Julia, and you will really enjoy spending time with Corrine. She's awesome. We kind of got this study published late last year in Lancet Psychiatry. We looked at the Viatris Clozaril pharmacovigilance system, and a huge thanks to the team at Clozaril psychiatrists making this available to us, and Julie was one of the co-authors on this paper, looked at all people who were commenced on clozapine from June 1990 through to October 2022, which is when we got the data set. So, there's 2 clozapine suppliers in Australia and New Zealand, but this database, because when people transition between the 2 different vendors, their data transitioned across as well. We probably got most of the people on clozapine in Australia and New Zealand that time period. We looked at anyone who started clozapine after 1990 when a record started becoming reliable. We had their first dose within 2 weeks of the first reported blood test and had more than a 0-week follow-up. So they actually were on clozapine. We kind of made the threshold for serious neutropenia as 1, and we called it serious with cessation if they stopped clozapine within 4 weeks, because there were some people who had serious neutropenia but remained on clozapine, and often they were on clozapine stopped on clozapine for other reasons. We looked at anyone who had serious neutropenia without cessation, so people who were still on it. Okay, so we had 26,000 patients involving 2.6 million pathology tests. They were on clozapine on average for a mean follow-up time of 4 years. If people were on clozapine for about 2 years, they were then on clozapine for 10 years. So again, finding that long time that people remained on clozapine. 2/3 male, which is 10% what we see in the treatment-resistant schizophrenia. And age initiation tends to be in the mid-30s. Again, an absolute tragedy because most people will have treatment-resistant schizophrenia long before that, showing the kind of a long time period often there is before someone gets started on clozapine after developing treatment-resistant schizophrenia. Okay, so this was a rolling weekly average of rates of neutropenia. We did a rolling average over 9 weeks because these are rare events. So sometimes you'll have little spikes with 1 or 2 people have an event in a week. So if we do a rolling average, it actually is much more meaningful. And what we see, these are people who had these isolated minor neutropenias, so a neutropenia of a threshold below 2, and this serious leading cessation. These were neutropenias where the levels went below 1. And you can see it's kind of high in the first 18 weeks and then drops off. And by about 2 years, it's pretty much a negligible number, whereas you're still getting people who are having these sort of minor neutropenias. And what this probably reflects is that if we were to do blood tests across everyone in Australia, we're going to get these people who've got serious neutropenia, but it's transient and just self-resolves, and we never know. And so this is probably the background rate of serious neutropenia, whereas this is this background rate of minor neutropenia. When we looked at the risks of competing risks, again, it was statistically much more likely to get this sort of isolated minor neutropenia rather than the serious neutropenia, suggesting that this is probably really a rare event and probably not clinically meaningful after about 2 years. So what we also found is that we had data on whether or not some of these patients were clozapine naive, whether or not they'd never had a trial of clozapine before. And if you were clozapine naive, you were more likely to have a serious neutropenia leading cessation than if you'd had a previous exposure. And what we kind of gleaned from that is that if you've had clozapine in the past and not had a neutropenia, and then later get re-exposed to clozapine, you're very unlikely to develop a neutropenia. So after 2 years of cumulative exposure to clozapine without any concerning absolute neutrophil count results, you could probably go straight back onto clozapine without monitoring if you had a treatment interruption. So again, as previous exposure decreased risks of minor and serious neutropenia leading to cessation, but not serious neutropenia unrelated to clozapine, because again, that's probably one of these background events that's happening, irrespective of whether you've had clozapine before. And so this again shows you the risks. So people in red have not had clozapine before. People in blue have had clozapine before, again, showing you that if you've had previous exposure, you're much less likely to have a neutropenic event. Okay, so the key messages from this are that clozapine-induced neutropenia is likely an immune-mediated event, which is why it's an early event. It occurs in the first 18 weeks mostly, effectively occurs usually in the first 4 to 6 weeks. And the biological mechanism suggests that there's reduction in risk with time on treatment. So, it's a biologically induced event, which is why if you haven't got it early on, you're really unlikely to get it later on. Serious neutropenia beyond 2 years is likely due to background risk, not necessarily clozapine. And we would argue that clozapine monitoring after 2 years is probably not necessary Moreover, if you've had 2 years of cumulative testing, you probably don't need to have neutrophil count testing after treatment interruption. Moreover, minor neutropenia doesn't increase your later risk of serious neutropenia. I jumped over that slide in the interest of time, because they're probably unrelated events. So we're now working to try and change some of the government monitoring policy around clozapine neutrophil count monitoring. Julia is sort of one of the people on the panel advising around this. I wouldn't expect this to change anytime in the near future. If you're a clozapine coordinator, I wouldn't be worried about your job today. It will take us years and years of tenacious campaigning to try and make this change in Australia and internationally. But gosh, Julia and I are very committed to going on a long journey for this. Okay, I've told you what the recommendations are. So cardiac. So we have a very high rate of myocarditis in Australia, and we're going to be presenting some of this information at Congress next week. Some of my really great colleagues, Laura McMahon, a psychiatry registrar in Toowoomba, Nikki Corman, a wonderful psychiatrist that I work with here in Brisbane, are going to present. I don't have their slides because I don't want to steal their thunder because they haven't yet presented it for the first time. But suffice to say that myocarditis, a rare event, usually occurs in the first month, increased risk with valproate. And I think someone had asked us about speed of titration earlier. The faster you titrate clozapine, the more likely it is that you'll develop myocarditis. Now, we have really high rates in Australia for some reason. Sort of 7 to 8% of people who get commenced on clozapine in some of our epi studies have developed myocarditis. And it's unclear why we have a higher rate in Australia. It could be because we titrate faster here. Over 2 weeks to 200 milligrams is actually quite fast, much faster than the recommendations by Jose de Leon in his titration schedule paper that was recently published. I think also we do a lot of detection. In the UK, it's not always standard to look for neutrophil, as far as biologists look for CK and troponin I for everyone who gets started on clozapine. So there may be detection bias so that we're seeing subthreshold transient myocarditis that self-resolves and would have self-resolved if we hadn't noticed it. But it's definitely higher here. Some people in the Northern Hemisphere have suggested it might be Coriolis effect related, which doesn't seem entirely plausible to me, perhaps koala related. So I won't go deeper into that, but we can have a conversation later if people have questions for me. So cardiomyopathy is, we have to do annual echoes. David Castle did some really clever research on this, which found that the cost per case detection was something like $400,000 or $500,000. And the incidence is rated at usually 0.6% in a meta-analysis we did. Very rare to die from it, but it's totally unclear whether or not it's clozapine that's causing it. The risk factors for cardiomyopathy tend to be alcoholism, obesity, diabetes, tachycardia. So it's unclear that it's a direct toxic effect from clozapine itself, but more the multimorbidity that's associated with schizophrenia and clozapine use that's leading to cardiomyopathy. And it remains remarkably unclear why we need to do annual echo monitoring. Nowhere else in the world besides New Zealand does this. All right, moving on to other serious adverse events. This was a really cool group from Kenya called Youth on the Move who did this pictorial diagram of what a seizure might look like. I just think it's a really cool name for an epilepsy group. Clozapine, we know, lowers the seizure threshold. Often it will present first with myoclonic jerks and focal seizures. The risk ranges from 5% beyond. We know that as the levels go higher, above 600 or 1,000, risk goes up. Again, one of the reasons I would argue, and I previously argued in my talk last year, that heroic doses of clozapine leading to high clozapine levels tends not to lead to greater response rates. It just tends to lead to higher rates of seizures and clozapine-related adverse drug reactions. So it creates additional burden on the consumer rather than necessarily benefit. There will be a small handful of patients who need a higher clozapine level to have a therapeutic response, but that is not the norm. I think we found it was like a number needed to treat of 42 once you get a clozapine level above 600 to achieve a response. Clozapine does cause non-focal slow wave changes on EEG. So if you do have an EEG for someone on clozapine, you will get these sort of changes. they're pretty normal clozapine. So if someone comes into your clinic with myoclonic jerks, the first thing you ask them is, have you recently quit smoking? And we'll talk, because we know that smoking does adjust clozapine levels. You may need to down titrate the clozapine dose. Consider a neurology referral. Think about an anti-epileptic medication. I really do not like valproate. I know it's in the Maudsley guidelines, and I'm trying to talk to David Taylor about removing that. Valproate increases your risk of myocarditis, increases your risk of neutropenia, makes you more obese, causes cognitive slowing, and it's got a number of genetic concerns around teratogenicity if it's taken either in men or women. And there's been a large UK report which is really causing us to question the merits of valproate. I tend to recommend lamotrigine, but that's a conversation that's usually a passionate one between myself and the neurologist. If someone comes into your clinic and has a seizure, what should you do? The answer is, and again, it's hard for us to communicate with this modality. The answer is call an ambulance, get them to the emergency department. You know, looking at brain imaging and EEG and neurology review, check the clozapine levels. If someone's got acute chest pain, palpitations, or shortness of breath in your clinic, send them to the emergency department. It requires urgent investigation to make sure they don't have any sort of cardiac issues. For patients with acute cold or flu-like symptoms and fever, that's not going to be explained by a cold, check the full blood count, make sure they don't have a reduced neutrophil count. Again, unlikely in someone who's been on clozapine for a long time. But you know, making sure that we're keeping an eye on that, particularly around pneumonia. Because we do have much higher rates of pneumonia among people with clozapine, possibly due to some of the immune modulation with clozapine. There's been some changes in IgG counts by a group in Cardiff, found some work that caused changes in clozapine IgG, but also scaleria leading to aspiration and aspiration pneumonias. All right, so I show you this picture here of this. There's a model who got a call from her agent who said, good news, you've been wanting to get this modeling gig for some time. We've got a shoot for you today. And then this poor model discovers this is what the shoot is. And I put that up there just to help make a little bit more emotional valence of this slide, because constipation is the #1 killer among people on clozapine. For those of you who've met me in person, you know that I carry a Bristol stool chart on my lanyard, because I'm bringing this up in clinic all the time to talk to people about their poo. Susanna Every-Palmer, a close colleague of Julia and myself from Wellington, New Zealand, worked in a forensic psychiatric hospital and was noticing that people were dying of ileus, lack of colonic transit movement. And so she gave people on clozapine what they call these SITS markers. They're little radio-opaque dots that you swallow, and then you can kind of take plain x-rays to see how fast colonic transit time is. Can anyone tell me what sort of the normal colonic transit time is for people, for the general population? How long does it take for people who are eating to pooping? What's the sort of, how long does it normally take to get through us? While I look for this, about 24 hours. Yeah, 18 to 24 hours is a normal colonic transit time. What they found was that people who were on clozapine, the median colonic transit time for people on clozapine without laxatives was 110 hours. I mean, that's like that's about 4 times or 4.5 times as long colonic transit time. What Susanna did is she got some rabbit colon and she put some sort of dissected it out and put it on agar plates, and you kind of can see the rabbit colon will still have peristaltic waves, and you could see the peristaltic waves even after it was on the agar plate. And she put a couple of drops of clozapine onto the rabbit colon, and it stopped. You know, there was no longer any peristaltic waves. Clozapine was that effective. And so with laxative, the median colonic transit time improves to around 67 hours, which is a heck of a lot better, but it's still slow. And so what Susanna would argue is that people on clozapine have got delayed colonic transit time until proven otherwise. And she recommends sort of starting with cloxylin senna as for a period for pretty much everyone on it, unless they're having diarrhea, and then looking at macrogol plus electrolytes, which is Movicol. Movicol is probably the most effective and most gentle, but one of the problems with Movicol is it requires you to put powder in water and then drink it. It's not a pill that can go in the Webster pack. There are some new medications now which are in tablet form, prucalopride. These are the secretagogues, which work on, I think, 5-HT4 or 5. I apologize if I get that wrong, but they're incredibly effective, but they're also incredibly expensive. And so we often will have our Department of Pharmacology at our hospitals declining to allow us to prescribe these. Okay. OCD is common in people with schizophrenia. We know that there's comorbidity between OCD and schizophrenia. Well, clozapine will increase the risk of obsessive compulsive symptoms. So if you do have someone who's got a worsening of obsessive compulsive symptoms, think about your dose, think about adding an SSRI, think about CBT, and those can be really effective for people who can tolerate them. Sedation, clozapine is really sedating. On average, most of the consumers that I serve will sleep between 10 and 12 hours a night. There will be maybe 10, 15, 20% who don't have any hypersedation associated with clozapine, but most people will sleep 10 to 14 hours. And I'm often talking to families who say, you know, my loved one is so lazy, all they do is sleep all day long, and you know, we should you know, stop the clozapine. But we remind them before they started the clozapine, these people were trying to cut their own penis off or tormented by auditory hallucinations. And so we really have to make this really difficult difficult balance between people being on clozapine who are able to return to work but are hypersedated versus before they were on clozapine when they couldn't, they were really struggling to remain their safety in the community. So clozapine sedation can be dose dependent, though it is kind of, there usually a threshold effect of when it's above a certain dose, that not a lot more sedation. But if you're giving hyper heroic doses with really high clozapine levels, that's probably going to make sedation even worse. Looking at the timing of the doses, I often have patients who tell me, look, I don't wake up until 2 in the afternoon. I said, well, what time do you take your medications? Oh, I take them at 2 in the morning. So encouraging consumers who want to get up earlier. A lot of my consumers don't want to be awake during the day. They want to be awake at night where it's quiet and they have to deal with their families. Telling them to take their medication earlier, looking at sleep hygiene and education. And then if things are in a bind, thinking of clozapine-sparing agents like amisulpride or aripiprazole. I do have a small number of consumers who take modafinil in the morning and find it quite beneficial to help them to wake up and go to work. I've had other patients for whom I've given modafinil in the morning and they said it's absolutely done nothing at all. So the evidence for modafinil for managing clozapine sedation is poor and anecdotal at best. Cialarrhea, again, common. Oh, there we go, Rahul. You asked about modafinil. There we go. I'm glad I could actually answer one person's questions accidentally. So cialarrhea, common. Most of the consumers that I work with report cialarrhea. Some people tell me that it gets better over time. So I've had a lot of consumers who've had it initially, it's gotten better. I kind of have got this rubric of how I approach it. So if someone has cialarrhea and it's not causing them choking at night, I'll usually recommend just a special absorbent pillow slip or a towel. Some of the consumers I work with put a t-shirt on top of their pillow and that's tolerable for them. If that's not tolerable, I usually recommend something like a sublingual ipratropium spray. That's Atropine nasal forte. And spray it under the tongue. It doesn't work if you spray it up your nose, which is what it's designed for. You've got to spray it under the tongue, but it's bitter and you can't drink any fluids afterwards. So it's not wildly helpful. But the reason I tend to use that first is it's very safe. There are some studies from an Israeli group which looked at amisulpride to reduce cialarrhea. So if I'm looking at a clozapine augmentation agent for someone who has got clozapine resistant schizophrenia and bothersome cialarrhea, I might look at amisulpride. There's been pretty good studies for diphenhydramine, which it's very easy to get overseas, but diphenhydramine Benadryl is pretty uncommon here, and diphenhydramine or other antihistamines will make constipation worse. For some consumers, I'll look at sublingual atropine drops. These are usually atropine 1% eye drops under the tongue. And I think Tim Lambert was involved in a study recently published, which showed that these sublingual atropine drops are pretty effective. However, there is a black box warning. One of the patients who was on clozapine accidentally drank the bottle and had a cardiac arrest. And so, obviously atropine is lethal in overdose. So you need to be very selective about which consumers you would use atropine drops for. You usually want to choose someone who's quite obsessional and quite rigid. Someone who's disorganized might well have risks of accidental overdose on atropine. Sometimes I will get consumers to get a small sort of shot glass of water and put two atropine drops in that water and swish and spit as a way to prevent them putting too much in their mouth. But I've got one consumer who was very organized, who's using 2 drops of atropine under his tongue, but the other day came and said that they still got problems, some sialorrhea, and they were having 10 drops of atropine at a time, which was terrifying. We've had to kind of really work with this consumer about helping educate him about the risks. More commonly used in the UK are hyoscine or quells, which this is usually lozenges, which are used for seasickness or travel sickness. Sucking on one of these quells lozenges at nights will cause the mouth to be dried out, though hyoscine will unfortunately cause increased rates of constipation, so you do need to be conscious of that. So some options around managing sialorrhea. Enuresis. So when I say to people, do you wet the bed at night? Everyone says no. When I say to people, some people who are on clozapine find it very sedating, and they fall asleep so deeply that they can forget to wake up to pee. And, these people sometimes wet the bed. I've had such a huge response, like 30–40% of people now tell me that they have sialorrhea, so I probably have enuresis at night. So you've got to normalize it to ask the question. Yeah. So I'm looking at the questions and answers, and I will what I'll do is at the end of the talk, I'll go through this and we'll talk about some of these questions you've got there. So normally I will advise people to empty their bladder immediately before they go to bed, reduce their fluids in the evening. So if they're going to go to bed at say 9 o'clock, stop drinking fluids at around 6:30 or 7. If that doesn't work, maybe setting an alarm at the middle of their sleep. So if they're sleeping, say, between 8 a.m. to 8 a.m., maybe setting an alarm at, so 8 p.m. to 8 a.m., setting an alarm at 2 a.m. so they can go to the toilet. And then usually people on clozapine who are that sedated have no trouble falling back to sleep. Looking at their sedation, thinking about other things to reduce the risk of their hypersedation, so reducing the dose of clozapine or clozapine-sparing agents. Using continence pads and sheet protectors. One of the advantages of the NDIS, because it does tend to be for a physical disability model, everyone gets access to a continence nurse. So a lot of the consumers that I've worked with who are on clozapine, who have NDIS packages, will get access to a continence nurse and get continence pads and sheet protectors, and people have found that to be really acceptable to wear, continence underwear at night. For people for whom this doesn't work, you could consider adding, desmopressin. Though desmopressin can cause electrolyte disturbance, so I'd be very cautious about using that. Some people I've given desmopressin have had really great response. Some people I've given desmopressin, they have developed hyponatremia and become delirious. So you've got to be very cautious about that. Sexual dysfunction is quite common. Some of it is driven by the diabetes, but some of it is driven by the serotonergic effects of clozapine. Consider referral to a GP. I've got one consumer who really wanted to have sexual relations again because their symptoms had improved. They've been able to develop a meaningful relationship, but they were unable to achieve erection and orgasm. And so we've recommended trying some Viagra, sildenafil, and they've had really good responses with that. All right, postural hypertension, again, really common. I now ask the wonderful clozapine nurses with whom I'm privileged to work to do a lying and standing blood pressure on everyone who comes to see in my clozapine clinic, and I'm stunned by how high the rates are of postural hypotension. That's greater than a 10 millimeter mercury difference between diastolic, or 20 millimeters mercury difference systolic. So very common. So I'm usually advising people to stand up slowly. So, go from lying to a sitting position, wait a minute, and then stand up slowly. Some patients have had it so bad, I've had to, I've had to use fludrocortisone. But again, fludrocortisone also has some electrolyte disturbance side effects. So I've had some consumers who've done really well on that and some consumers who've become delirious. So you do need to be cautious. Tachycardia, we're doing some work at the moment with rates of tachycardia. What we're finding is that there's pretty high rates of tachycardia above 100 beats per minute, pretty soon within sort of 5 or 10 days of starting clozapine. The rates above 120 beats per minute are less common. It's hard to know what the threshold is for treatment. Usually 120 beats per minute is sort of, maybe think about treating at that point. Most cardiologists, there isn't really a certain number of beats in your heart. It's more whether or not you're having symptomatic problems associated with tachycardia. But you might want to consider a beta blocker, maybe a tenolol. If your service will pay for it, avabradine is a direct tonic agent which tends not to cause blood pressure changes. So avabradine can be a good choice, but it is not yet on the PBS for this indication. Most people on clozapine will get nausea, vomiting, heartburn, and reflux. Most people that I work with have gastroesophageal reflux disease. Again, clozapine causes a slowing of the gut motility, so I'm usually adding a PPI. Though bearing in mind that omeprazole can sometimes alter clozapine metabolism. So pantoprazole is usually a pretty safe bet. Smoking. So this particular gentleman here is probably smoking a little more heavily than a lot of the consumers that we work with, but most of the consumers we work with will smoke pretty heavily. One of the things that's notable about people with schizophrenia is that they will smoke more of the cigarette, they'll inhale more deeply. And most of the consumers that I work with who smoke will smoke 30 or 40 cigarettes a day. So it really is a challenge for us to manage cigarette smoking among our population. We'll talk about that a different day. But clozapine levels are impacted by cigarettes because of the polycyclic aromatic hydrocarbons in cigarette smoke. And so these ones induce cytochrome P450, 1A2, which is one of the major clozapine metabolism pathways. So if you suddenly stop smoking, like you have been admitted to a medical facility with pneumonia, you're going to get this significant increase in your clozapine levels. So we really recommend reducing clozapine dose by about 1/3 when someone has an acute admission. Also worth noting that infections and inflammation will also cause a spike in clozapine levels. So all more reason to be really checking clozapine levels for anyone who gets admitted to hospital who's smoking or has an infection. The clozapine dose may need to be increased if someone suddenly starts or increases cigarette smoking. So this is going to be an issue when people leave the ward after clozapine has been initiated and they go back from not smoking in theory. I think a lot of people still smoke on our wards, but in theory they're not allowed to. They leave the ward and they start smoking 40 a day again. We'll have to adjust their clozapine dose upwards. Bear in mind that it is the polycyclic aromatic hydrocarbons, so it's not the nicotine. So if someone starts vaping or using e-cigarettes, then that's not going to induce their CYP1A2. So e-cigarettes won't induce it. It's not the nicotine. It's the polycyclic aromatic hydrocarbons. If someone is smoking sort of 20 joints a day, they'll also have that similar effect, particularly if they're using spin in their marijuana. All right, and finally, in the last few minutes, metabolic. Clozapine has the worst metabolic profile of any antipsychotic. Over half will have metabolic syndrome. Almost half of the patients that I have on clozapine long-term develop diabetes. It's a really common problem. Dietary interventions and exercise are really important, but much like the Stop It, Don't Swap It campaign, where the government said, don't eat this spaghetti bolognese, eat a salad, Australians didn't go for that. And much like this cat, getting them to do exercise can be challenging. So similarly, it's very challenging to encourage our consumers to follow through on exercise. So for that reason, metformin has got some really good evidence. And we've done some recent studies which have shown that metformin co-commencement with clozapine can actually be fairly effective in ameliorating clozapine-induced weight gain. Julia and I have been working on some studies of GLP-1 receptor agonists, and they seem to be very effective as well for managing weight among people on clozapine, though supply remains an issue. So what I might do now is I might stop now to make sure we've got some time for a conversation with you guys. And happy.
So much, as always, hugely informative and very entertaining, and lots of audience participation, which is fantastic to see. I would just encourage everybody now just to take a moment or two to pen your questions to Dan into the Q&A, and we'll systematically go through those. While you're doing that, Sarah's just going to share a couple of slides from TRSP just to let you know what our next webinar series, what's next coming up in our webinar series. Just before we do that though, I just want to make you all aware that there is a TRSP scoping study currently underway, and this QR code is your entry point to participate, and we would be delighted if you could take part. Sarah has also shared in the chat the link to that survey, which asks for your feedback on what confidence you have in delivering certain skills when working with people who experience psychosis, and particularly complex psychosis. And this work will shape a gap analysis of training needs for us to develop future training and education. Thanks, Sarah. Then the next slide just showcases our speaker for next month, who I'm delighted to say is Professor Sarah Bendel, who is the head of the Trauma and Youth Mental Health Centre at Origin in Melbourne. And Sarah's going to talk to us about trauma and psychosis. This was the topic voted highest in your priorities when we polled last year for topics to be covered this year. So we look forward to seeing you there. And then just the last few slides before I hand back to Dan. If you've any queries about the tertiary referral service for psychosis, you can find us at this email address. And then just reminding everyone that we are sponsored and come under the umbrella of the Mindgardens Neuroscience Network. More information can be found about Mindgardens at these sites. So we'll just stop screen sharing now. And I will, Dan, talk you through all the chat questions. I can see that, I know that you have access to them too, but
yeah, I would love if you pick some out. If you could pick some out for me, I'd love that.
Yes, all right, no problem. So I'll start with the question that was asked by Tim McRae. So Tim's asking, is there any correlation between the number of antipsychotics and myocarditis?
We've not found it, but we have got a data set which we're going to look at and analyze, but it doesn't seem that polypharmacy increases the risk. However, sodium valproate does. So there is a definite relationship between being on sodium valproate at the time of clozapine initiation and higher rates of myocarditis. So not necessarily polypharmacy, but 100% sodium valproate is a problem, increases the risk.
Okay. Okay, and you've talked about valproate during the talk, so that's one to avoid, and your preference would be lamotrigine.
Usually it's lamotrigine, though. If you talk to the neurologist, they will say, well, look, valproate's the best for myoclonic jerks. So it's a bind. I'm not a neurologist. I tend to prefer people to be on lamotrigine, but I have passionate debates with my neurology colleagues.
Right. So Dan, you talked a lot about side effects today, which was really fantastic, because I know from the chat and also from multiple discussions with colleagues that side effects can be a limiting step for increasing the dose of clozapine. And sometimes that troubles us because it means we're not getting the clozapine blood levels up to what would be considered therapeutic. Is there a role, Rahul Gupta is asking, is there a role for modafinil in managing therapy-limiting sedation?
Yeah, so again, I mentioned this, I think, just well, or I'll put the question up there. I have offered modafinil to some consumers who found it very beneficial. Some consumers have not found it beneficial. It is expensive, and you need to convince someone to pay for it. But some people have found it very helpful. Others have found it not helpful. Worth a try.
So worth a try. Yeah, but not much evidence to guide us on that one? No. Okay, great. Now, Kim is asking...
Patients say it's like having 2 strong cups of coffee is what the patients tell.
Okay, okay. So Kim's asking, as far as amisulpride and sialorrhea go, is this a dose-dependent relationship, or at what dose?
Don't think it is dose dependent. I think 100 milligrams of sialorrhea, so 100 milligrams of amisulpride might be useful for sialorrhea. It doesn't seem to get better on a higher doses. But I don't know if anyone's done good studies on that. I think the original study had just looked at a low dose of amisulpride. They're kind of a class of medications of antipsychotics, including metoclopramide, which also kind of, and prochlorperazine all cause reduction in sialorrhea, but have other sort of side effects.
Okay. Now, Dan, this is a great question that's been posed by Dr. Michele Meltzer. This comes up often in people that I see within TRSP. Some people recommend the fluvoxamine-clozapine combination to modulate some of the side effect profile, including appetite and sedation. Do you have comments?
Yeah, so I've not found that fluvoxamine will alter the clozapine to norclozapine ratio because it will competitively inhibit cytochrome P451A2 and therefore cause higher clozapine levels and lower norcloz levels. Although the clos-norcloz ratio has been studied, we haven't found a lot of evidence to suggest the clos-norcloz ratio impacts adverse drug reactions remarkably. So I'm not sure it's going to be useful for managing sedation or cialorrhea or those sorts of things. Where I find it useful is that you will have a proportion of people on clozapine who are fast metabolizers, who you can give them sort of 800 milligrams of clozapine and their levels will still be below 150. So I will use fluvoxamine for consumers who are clozapine fast metabolizers, and you can tell that without a genetic test because they metabolize clozapine quickly, and I'll use that to kind of help bump the clozapine levels up. Or for some consumers, I've said, I'm not going to take more than 200 milligrams of clozapine. I said, well, what if I give you some fluvoxamine? And then suddenly their symptoms will get better because their clozapine levels have gone up. And so sometimes you can negotiate it with consumers who are very fixated on doses to use a little bit of fluvoxamine.
Thanks, Dan. Julia Mackay is asking, do you have any comment on clozapine storm or inflammatory responses other than myocarditis early in treatment? In such a scenario, should clozapine be ceased or can it continue if myocarditis is excluded?
I had a patient recently who has just been tortured by his symptoms, got started on a low dose of clozapine, had a massive improvement in his symptoms, but developed serositis. And so he had this clozapine storm of serositis. And so this person cannot be challenged with clozapine tragically.
Yeah, and a related comment from Cindy Shannon Weichert. So first of all, she thanks you, Dan, for an informative and entertaining talk. Thanks for bringing up the IgG study. Associations between Ig reduction and symptom improvement indicate that the immune system blunting may be part of the benefit from clozapine. Do you have any comment?
No, Cynthia, I'd hoped you would ask me this, and I'd love to actually sit down with you and have a longer conversation about this. So this is one of the postulated mechanisms, is that there is immune modulation which is occurring with clozapine, which is leading to reduction of symptoms. I know that you guys have done some of these immune modulator studies. Tricky and hard to know. So it's possible. It is completely possible. I don't think we know well enough yet. Weirdly, during COVID, everyone was looking for a treatment for COVID. And I got all these emails from immunologists around the world asking me what should we be giving people with COVID clozapine because of its immune modulating effects. I didn't think it was a good idea, but it does really raise that really important question, Cynthia, and I'd love to chat to you about it one day.
Well, maybe we'll make that possible one day, Dan. All right, so Rahul Gupta has a further question. Does clozapine therapy make patients more resistant to other antipsychotics?
I think so. I think that you get onto clozapine because you've got clozapine-resistant schizophrenia. I don't think there's a kindling response caused by clozapine.
No, I've never heard of such.
Often you've got people who fail clozapine and you're really in a bind as to what other options. Sorry, Julia.
No worries. Just a couple of questions to finish, Dan, then we're going to run out of time, sadly, before we get through them all. For someone displaying increased OCD symptoms with commencement of clozapine, but where there is better control of their positive symptoms, would you lower the dose and introduce an SSRI?
Yeah, so I've had a number of consumers who've had troubling OCD symptoms. The first thing I'm going to do is I'm probably going to introduce an SSRI first before I lower the clozapine dose. If I can safely lower the clozapine dose without a return of symptoms, I might try that. But some patients, that's not going to be feasible. So adding an SSRI or doing CBT for OCD for some of the consumers who are quite rigid and obsessional but cognitively minded can be really beneficial. Again, watch out for fluoxetine, which can raise clozapine levels, and obviously fluvoxamine.
Okay, and a last question, but probably not a quick one, but I'll throw down the gauntlet. Suggested strategies for augmentation, Dan.
Again, we covered that last year, Julia. And if you,
so we can refer people back to your last webinar, which is on our website.
Or I'm happy to come again another year and dig deeper into that if that would be of interest to your audience, or talk about multimorbidity or other sort of topics. I'm always honoured to be invited to come and speak to Mindgardens and your referral service.
Thank you, Dan, and thank you because you really are our international expert in clozapine right here in our own backyard. So thank you very, very
66-year-old
much.
drug that no one else cares about. I really my
We
target.
care. We care. All right, everyone. I'm going to say goodbye. Thank you for your attendance today. And thanks especially to Dan for another great talk. Bye, everyone.